Good evening, everyone. At the outset, actually, let me quickly run through our slides because it is getting quite significantly late. So, today's our panel discussion is all about chemotherapy-induced neuropathy, and I would like to invite our panelists, actually, Dr. Sushma Bhatnagar, ma'am, Dr. Ankita Singh, ma'am, Dr. Atul Narayankar, sir, and Dr. Vinayak Maka. So, let us move to the presentation quickly. So, next slide, please. So, what is neuropathy? It is any condition arising from the damage or the dysfunction of the peripheral nerves, including motor, sensory, and autonomic nerves that connect the central nervous system, including brain and the spinal cord, to the rest of the body. And it is one of the most common chronic complications of the cancer and its treatment. Chemotherapy is just not a hit and run drug, actually. And we all know that neuropathy is something which can hamper the quality of life significantly. So, what is the pathogenesis of CIPN? So, if we see the pathogenesis of CIPN and the involvement of various sites in the peripheral nervous system, there are practically all chemotherapeutic agents that act on the various sites of the peripheral nervous system. So, what are the grades of peripheral neuropathy actually? As per the common terminology criteria, version 5, so the grades of peripheral neuropathy are grouped into two parts. One, grades of the peripheral motor neuropathy and grades of the peripheral sensory neuropathy. So if we see the grades of the peripheral motor neuropathy, there are 5 grades, right from grade 1, which is asymptomatic, clinical or the diagnostic observations only. Grade 2 is moderate symptoms, limiting the instrumental activities of daily living. Grade 3, severe symptoms, limiting the self-care activities of daily living. Grade 4, life-threatening consequences and urgent intervention is needed, and grade 5 is death. Likewise, there are grades of peripheral sensory neuropathy. Grade 1 is asymptomatic. Grade 2 and grade 3 are similar as that of peripheral motor neuropathy. Grade 4 is life-threatening consequences. Urgent intervention is indicated, and grade 5 is not graded. So if we see what does that mean, basically the activities of daily living. So these are actually divided under two headings: instrumental activities of daily living and self-care ADLs. Instrumental ADLs are affected in grade 2 and self-care ADLs are affected in grade 3. So that means whenever there are self-care ADLs are affected, the severity of neuropathy is more. So coming to the case discussion for the panel today, so I have put forward two case scenarios. One patient was treated with curative intent and another patient was treated with palliative intent. So the patient which was treated with curative intent, she was a 52 years old lady, postmenopausal, with comorbidities of diabetes mellitus, and she was diagnosed with carcinoma left breast, which was triple negative breast cancer, and it was a locally advanced breast cancer. So she was treated with neoadjuvant chemotherapy with dose-dense protocol, especially AC 4 cycles followed by paclitaxel 4 cycles. Then subsequently she underwent surgery and adjuvant. The point in this sequence of treatment events is basically after 2 cycles of paclitaxel, she started complaining of tingling and numbness, not interfering with the activities of daily living. But as the chemotherapy proceeded, symptoms worsened after the third dose of chemotherapy, and she presented with imbalance while walking and had to delay and reduce the dose of paclitaxel for the last dose that was remaining. Another case scenario is basically, next slide please. Another case scenario in which patient was treated with palliative intent, 68 years old gentleman with comorbidities of hypertension and diabetes, ECOG performance status of 2, diagnosed with adenocarcinoma of descending colon with hepatic metastasis, and the patient was treated with FOLFOX regimen for 4 cycles initially, and then after 4 cycles he showed partial response, so the FOLFOX was continued for 4 more doses. But what happened in between? After 5th cycle of FOLFOX, he started getting numbness of fingers and toes. So occasional sense of burning sensation in night, at times disturbing his sleep. So these are the two situations, and I would like to ask the panelists now on the given clinical scenarios. So we have in the first case scenario, we have a clinical diagnosis of paclitaxel-induced neuropathy, and in second case, we have oxaliplatin-induced neuropathy. So I will start from Vinayak sir. Sir, Vinayak sir, you are there? Atul sir is there? Hello.
Hello. Yes, yes.
Hi. Sir, actually, we have you gone through the case
Yeah,
scenarios?
yeah, yeah,
Yeah.
yeah.
So my question to is basically, what is the incidence of chemotherapy-induced peripheral neuropathy in your clinical
Yeah.
practice?
Yes, yes. So I think every 1 out of 3 or 4 patients, I think I think in the like every third patient when you are treating, I think had some kind of some grade of a neuropathy is what I see in my practice.
Yes, yes. So we can see the magnitude of the disease burden. So almost 25 to 35% of our patients actually develop peripheral neuropathy. Atul sir, one more question actually. Which factors actually do you think act as an additional risk factors in such situations?
So I think the additional risk factors will be other comorbidities like uncontrolled diabetes, old age, any I think vitamin deficiencies like B12 deficiency, history of chronic alcoholism, or previous existing neuropathy. All this I think can be contributing whenever we are like we should consider for all this comorbidity whenever we start with any drug which can induce a neuropathy.
Yes. Sushma ma'am, you are there?
Yes, I am here. Yeah.
Yeah. Ma'am, needs your inputs actually in on these two questions. So, what is the percentage of the patients reaching you for the management of the chemotherapy-induced peripheral neuropathy, and which additional risk factors do you think act as an additional inciting event in such patients?
So, in first case, I think with paclitaxel, oxyplatin induced, I think almost 20 to 30% of patients they come with various grades of neuropathy. But in severe grade, I think it is 5 to 10%. Uh, uh, the most important additional risk factor is, as Dr. Atul has said, that uncontrolled diabetes is most uncontrolled diabetes, as well as if a patient is diabetic and is on oral hypoglycemic or insulin. I think we have to be very cautious. Plus, some kind of any other. There are many patients they have a vitamin D deficiency or vitamin B deficiency. These patients
Yes,
are also at risk. Plus, old age is a risk group.
yes. So, next slide, please. So, just now we discussed the incidence of CIPN and almost 30 to 40.
Yeah. So as we have discussed, these are the additional risk factors for such as age, pre-existing neuropathy, and genetically determined factors. So these are the additional patient-related risk factors actually increasing the risk of cancer and its treatment-related neuropathy, and it includes metabolic derangements, toxic metabolic disorders such as diabetes mellitus, vitamin B12 deficiency, alcoholism, paraproteinemias, critical illness neuropathies, or history of idiopathic disorders such as GBS or CIDP. So my question to the panelists, Vinayak sir, are you there? I think he's not there. Atul sir?
Yeah, hi.
Hello?
Yes.
Yeah.
Hello.
What are the symptoms that your patients face that indicate possibility of impending neuropathy, sir?
Yes. So probably the initial symptom what they come up with occasional tingling and numbness at the tips of the fingers, and yeah. So usually that is the symptom, and then the involvement to keep on increasing as you keep on giving the similar doses. So these are the typical the symptom that I come across in my practice.
Okay. Sushma ma'am?
The initial symptoms, as Dr. Atul said, numbness and tingling. But as the time progress, and if because especially in the second case, the CA colon patient, as the time progress, these symptoms keep on increasing, and if there is a additional risk factors are there, these symptoms keep on increasing, and finally, initially it is tingling and numbness. The numbness start persisting, and then it converts into the pain, and patient starts feeling pain, and then they are unable to do their daily activities. It is not only in the finger and toes, but it is also in the finger toes also, and patient they are unable to walk, they are unable to keep their feet down on the floor. So in the severe stage, but even the tingling and numbness, they really it becomes sometimes crippling for the patient, and they start saying that this is really troubling us. So we need to prevent it rather than
Yes.
like waiting for this time to come.
Yeah. Vinayak sir, you have joined. So my question to you is basically, what are the symptoms that your patients actually face that indicates the possibility of impending chemotherapy-induced peripheral neuropathy?
It depends on the what drug we have given. In our practice, most common is oxaliplatin. They have tingling sensation, and progressively they feel very a lot of positive symptoms will be there, tingling sensation and unable to think. It's a progressive. Some of around 25% of patients will have permanent that kind of thing. It reverses initially with pregabalin. Once chronicity sets in, even pregabalin doesn't help. That's one. Second, other conditions like VCR in children, that all the motor symptoms will be there. These are the main thing. I have not seen very cisplatin related peripheral neuropathy,
Okay,
but
okay,
these are the few things.
okay,
Paclitaxel.
okay.
Paclitaxel is
Fine.
one more.
So, if we see the clinical signs of chemotherapy-induced peripheral neuropathy, especially sensory, it totally depends on what are the medications that are being used. They're affecting sites, whether they are affecting large fibers or small fibers, and based on those, minus symptoms and plus symptoms. So, plus symptoms are such as tingling, pins and needling, permanent burning, lancinating pain or jabbing pain. Minus symptoms such as decreased vibration sense, decreased proprioception, decreased pain and temperature sensation. And it is said that only plus symptoms may be pharmacologically treated. It becomes very difficult to treat these patients who have minus symptoms. So, clinical signs in motor neuropathy, what are the minus symptoms and plus symptoms? Plus symptoms include fasciculations and cramps. Minus symptoms include distal weakness, hypo or areflexia, atrophy of the muscles, and deformities such as space cavus. So there are certain autonomic group of clinical symptoms actually, especially chemotherapy induced, and these include constipation, postural hypotension, reduced heart rate variability, disturbances of the bladder, delayed gastric emptying, and these are the medications which can cause these symptoms. So whenever we anticipate clinically diagnosed peripheral neuropathy, which is chemotherapy induced, how will you proceed? What are the various strategies of chemotherapy-induced peripheral neuropathy management in your practice? Atul sir?
Yes. So I think first and foremost is the dose modification or reducing or changing out to another medication which has a lesser neurotoxicity. That should be the first go. Then whatever additional treatments you do, I think it just only kind of reduces the symptom. You may not be treating the underlying cause, which has caused the nerve damage. Usually, as a symptom relief, I usually start the patient either on a deloxetin or pregabalin, and we obviously take help of the non-pharmacological measures like sometimes physiotherapy and acupuncture.
Yes. So the various strategies actually of CIPN management, right? It starts from basic evaluation. So basically, we need to involve specialized neuromuscular assessment specialists into the care, and we need to go into the details such as comprehensive history, comprehensive physical examination, electrodiagnostic testing as appropriate or indicated by the patient's condition, nerve and or muscle biopsy as appropriate, and imaging as appropriate. So basically, the patients with peripheral nervous system disorders present prior to the initiation of neuropathic chemotherapy have increased risk of getting such kind of chemotherapy induced peripheral neuropathies, and specialists should be involved in the care of such patients, and we should start working right from reducing the risk of developing chemotherapy induced peripheral neuropathy rather than focusing more on crisis management after the development of peripheral neuropathy. Next slide, please. So these are the various strategies of managing CIPN: dose reduction, dose delays, and medical management. Vinayak sir, how you proceed actually in your practice whenever you anticipate such kind of CIPN?
Actually, there's not much of preventive measures we can start, but we have to be very alert. We should be very judicious to ask the patients. So dose reduction I do, and especially coming to oxaliplatin, we increase the duration of infusion. It also helps
Yes,
actually,
yes, yes,
and those delays don't help it as I see
yes,
much of things.
yes,
Usually pregabalin, if you start early, it usually helps with oxaliplatin related neuropathy.
yes.
Paclitaxel doesn't go with anything. I mean, been very not very fruitful in paclitaxel induced one. PCR, yes, definitely dose delays, dose dense, and even reducing the, for example, adults patients, we give pediatric protocols. We have to be very careful with VCR. And autonomous dysfunction is the one which is very difficult to treat. This is just my personal experience.
Yes, yes. Sushma ma'am, what are your strategies whenever a
So,
patient with CIPN comes to you?
first and foremost thing which really works well in any CIPN patient is counseling. That this happens, we are trying to reduce it with the medication. May not be able to reduce completely. We may not be able to reduce completely, but definitely your activity and exercise means continuing your activity in spite of this will really help. Then the drug in the drug we usually use is pregabalin, gabapentin, and some duloxetine really works. But definitely all these drugs have side effects. Most important thing which works in our patient, we use non-pharmacological management, that is TENS and scrambler therapy. We have almost 5 publications in the leading journal of pain on scrambler therapy for the chemotherapy-induced neuralgia. So, non-pharmacological management really works well in these patients. So, I think we should try to reduce CIPN with the help of counseling and non-pharmacological therapy. So, keeping scrambler therapy in all the hospital is not easily possible, but we can definitely have TENS machine. TENS machine is very simple and very cheap, and any occupational therapy therapist and physiotherapist of your hospital, they must be knowing how to use it. So it really works well in patients with chemotherapy induced neuralgia, and we should try to, even the IASP, International Association of Study of Pain, guidelines says that treating all these patients with non pharmacological therapy is much better than by giving medication, because all medication have side effect, and people most of the time their quality of life not only deteriorate with the CIPN but also deteriorate with the side effects of the medication.
Yes, ma'am, can you brief on that scrambler therapy that you are talking about?
Scrambler therapy is basically is a therapy which works on the principle of TENS. So we know that there is a gate control theory of pain. So when gate opens, the patient starts feeling pain. But when the sensation which fibers which the pain fibers which they are taking the pain sensation, by giving scrambler or by giving TENS or by giving stimulation on the peripheral nerves, these pain sensation changes into the some kind of a pleasant sensation. This is what the principle of scrambler, although
Okay,
the
okay,
exact principle is not known,
okay,
but basically this mainly works with the principle of TENS. The principle of TENS?
okay, okay. Next slide, please. So basically, this is an overview of various drugs and their doses used in the management of CIPN. So anticonvulsants or anti-epileptics such as calcium channel blockers, sodium channel blockade, sodium calcium channel blockade, and commonly used drugs that we use as a medical oncologist. These are actually pregabalin and gabapentin. And up to certain extent, we go up to tricyclic antidepressant (TCA) such as amitriptyline or nortriptyline, and in certain situation we also use SNRIs, that is serotonin norepinephrine reuptake inhibitors, that is duloxetine. Next slide, please. So basically, this is what a nutshell what the NCCN guidelines actually recommend, especially in the management of cancer-related neuropathic pain. And as Sushma ma'am has depicted, that we use mainly non-pharmacological measures, as well as Vinayak sir has depicted, that we use commonly pregabalin, duloxetine, and other SNRIs or tricyclic antidepressant. So this is basically a nutshell overview of various medications along with their doses. Next slide, please. So we often manage these patients by starting duloxetine or pregabalin or gabapentin, and according to the treatment of the neuropathic pain, try to get relief of plus symptoms with the membrane stabilizing agents such as gabapentin or pregabalin, TCAs. Local therapy, topical baclofen, amitriptyline, ketamine, topical low concentration menthol or capsaicin. Sushma ma'am, how these local therapies are actually effective in the management of peripheral neuropathies?
These local therapy, like all these, I have not used, but definitely capsaicin is recommended in many of the patients. Even the ketamine burst therapy we have not used for chemotherapy induced neuralgia patient, but definitely in patients with the brachioplexopathy and severe brachial plexus neuropathy, we have used ketamine burst therapy. But topical drugs, most of the time we have not used, but capsaicin in these days working well in our patients.
Okay. Next slide, please. So what is the natural course of the CIPN? Next slide, please. So there is something called as coasting phenomenon. That means worsening of symptoms after the cessation of therapy, and it may last up to 3 months. And it is one of the commonest thing that we see when the patient is exposed to the platinum compounds. There could be partial recovery with residual deficits in most of the patients. There could be drugs persisting in the nerve roots after finishing the therapy, and that is causing ongoing toxicity, especially in taxanes, paclitaxel. There could be improvement in neurophysiology, which is usually poor in such patients. Clinical improvement might be there, but in neurophysiological studies, improvement may not be that significant. Different grading scales for evaluation limit evaluation. So basically, this CIPN has different outcomes as such. Any preventive strategies do you practice in your practice? Next slide, please. So as we have already discussed that preventive strategies doesn't actually help too much, especially pharmacological. So most of the times actually non-pharmacological intervention we need to like emphasize on acupuncture, cryotherapy, compression therapy, using surgical gloves or exercise. Next slide, please. So physical exercise, physical treatment is effective, should be focused on the exercise of distal motor skills, power and endurance of activity, body coordination and balance. That's what actually Sushma ma'am was talking about. Next slide, please. So these cryotherapeutic agents, I'm actually of doubtful value because we have not used them, and the actual patient compliance or tolerance of the patient to these therapies is also little bit of doubt. Next slide, please. So take home message from the panel discussion of CIPN. CIPN is a dose limiting side effect in cancer therapies. Diagnosis of CIPN can mostly be established in clinical examinations itself. No prevention is available at the particular moment. Duloxetine shows efficacy with moderate evidence. Diagnosis and treatment of CIPN should include functional parameters such as anxiety, depression, and sleep, where the counseling plays a role. Only plus symptoms of sensory neuropathy can be treated effectively, and spectrum of central toxicity has widened and includes immune mediated processes in new cancer therapy agents. Next slide, please. Thank you so much for the patient panel discussion, and I again apologize on the part of the organizers for being delayed. Thank you so much. Yeah.